Good morning. This is Laura Kaiser, Advanced Practice Registered Nurse, Wound-Ostomy Continence Nurse, presenting today on diabetic foot ulcers. Now we're going to go to this website and listen to about 2 minutes from a patient's perspective when a patient is told that they may have to have an amputation because of a diabetic foot ulcer. Lower extremity neuropathic disease is one of the 3 lower extremity diseases, and the patient with the lower extremity neuropathic disease has the lower extremity neuropathic ulcers, also called diabetic foot ulcers. And Hansen's disease patients who have leprosy also have the neuropathy, which is present in patients who end up with neuropathic ulcers. The diabetic foot ulcer belongs to the patient with the insensate foot. The insensate foot is known as a blessing and a curse, and is referred to this in the lower extremity amputation prevention program that is available to healthcare professionals in Baton Rouge. The blessing is that if the patient has this ulcer, it doesn't really hurt them, but the curse is because they can't feel, they end up with this ulcer. So you can understand how the insensate foot or the neuropathic foot can be referred to as a blessing and a curse. So the treatment for diabetic foot ulcers is debridement and offloading. So the pressure is on to take the pressure off of the diabetic foot ulcer, and this promotes wound healing. Patients at risk for developing foot ulcers are those who have a previous amputation, if they have a past history of foot ulcers, patients with peripheral neuropathy, patients with a foot deformity, patients who have peripheral vascular disease, which can be arterial or venous, but mainly arterial. Patients who are visually impaired, this prevents them from assessing their feet or looking at their feet every day. Patients with diabetic nephropathy, especially the patients who are on dialysis. Patients who have poor glycemic control, and patients who smoke cigarettes. It decreases the arterial circulation. So these are the risk factors that for patients to develop foot ulcers. The standard treatment of the diabetic foot ulcer is to debride the non-viable tissue, which includes the callus, offload the pressure from the injury site, provide a clean, moist environment for the wound if the patient already has the ulcer, optimize their nutrition. But remember, diabetics, we have to be really careful. They need to follow their diabetic diet while optimizing their nutrition. Maintain adequate glycemic control. Treat their infection if they have it as needed. And it's not always infected. Remember our contamination to infection scale. And revascularize as needed. If they don't have arterial circulation, they may need a consult to a vascular specialist. And that's where our interdisciplinary team comes in, and you as nurses are part of that team, remember. There's diabetic foot education for healthcare providers, and there's the low extremity amputation prevention, which is a comprehensive program that can dramatically reduce lower extremity amputations in patients with Hansen's disease or any condition that results in the loss of protective sensation, especially diabetics. This program was developed by the HRSA National Hansen's Foundation Disease Program in 1992. This is the form used to register for the Diabetic Foot Education Program in Baton Rouge. It's called the LEAP Comprehensive Management of the Neuropathic Foot and Casting Lab. It's held twice a year, and they take the first, I think, either 20 to 40 Applicants, registration is free, attendance is free, but it does come on first come, first serve, and it is in Baton Rouge. I strongly recommend that you attend this program if you have any desire to become a foot care nurse. Then we have diabetic foot education for the patient. There's a lot of education, and I'll hand out a booklet that we have permission to copy and present to our patients. It's a really simple booklet to follow, and it helps the patients to understand the importance of diabetic foot and the importance of proper footwear. These are some examples of offloading. We have the total contact cast on the top left. This is one of the things that you're taught at the program in Baton Rouge. We have the felt pad offloading on the top right. This pad actually sticks to the patient's foot, but it provides an offloading device, pretty cheap, for the patient to wear with their shoe, and it keeps the pressure off of the diabetic ulcer. Same thing in the bottom left. The bottom right is the the bottom right is the Darko shoe, and it's sometimes wedged or not. This one is wedged, and this provides relief of pressure for the forefoot or the toes. And we know the treatment is offload, debride, and can't say that enough. These are some of the methods of wound debridement. We have selective and non-selective. It goes into the level of training needed to perform these types of debridement. What's the time frame? How fast can we debride the patient? What setting do we need to perform it? And is it appropriate for patients who are on bleeding precautions? Selective debridement includes sharp, enzymatic, autolytic, and also maggot debridement, which is not listed on here. The level of training needed for the sharp or surgical, you need to be a licensed physician, practitioner, or physical therapist, and need to be credentialed in those areas. The good thing about sharp surgical is it's immediate. You take away the necrotic tissue right there, and it's gone. You don't have to wait. The setting can be in the physician's office or the home or the bedside for small wounds, but if the wounds are larger and require more intense debridement, then we recommend the OR. Sharp debridement is not appropriate for patients on bleeding precautions. However, if the patient is taking medication, a blood thinner, then sometimes if sharp debridement is the debridement of choice, then the patient will have to hold those medications for a certain amount of days. The next selective is enzymatic, and we know Santil, that's the only prescription enzymatic. And we can all do that, the nurses and the physical therapists. We can do it at home or bedside. It takes longer than sharp surgical, but there's different things we can do to decrease the time frame to the full debridement. And it can be used for patients with bleeding precautions. Autolytic is another one that's selective, and we can do it as a nurse or physical therapist. It takes longer, but like I said, with the enzymatic, we can combine methods to decrease the time frame. This can be done at home or bedside, and it is appropriate for patients with bleeding precautions. Then we have the non-selective, wet to dry, which is very painful and not used as much anymore. Some doctors still order it, and sometimes it is appropriate, but not as much as when it used to be. It's very painful if done right. The nurse or the physical therapist can do it. You get pretty quick results, quicker than the enzymatic and the autolytic, and it can be done at the home or bedside. It's not appropriate for patients with bleeding precautions because when you tear that dry dressing off, it causes a lot of bleeding. Whirlpool or pulse lavage can be done by a physical therapist. You get pretty good results. Physical therapy department or bedside is sometimes done in a hospital setting, and you need to be really careful with the bleeding patients. Neuropathic ulcers, also known as diabetic foot ulcers, we want to offload and debride. And here's the foot screen that I'm going to add as an attachment, and this is what we should do on all of our diabetic patients, especially on admission. Here's the foot risk classification, not to be confused with the Wagner scale, but this is the risk classification and what we should do, the treatment recommendations. Risk 0 is no LOPS, which stands for loss of protective sensation, and no PAD, which stands for peripheral artery disease. The treatment recommendations are patient education, and it's recommended that the patient follow up annually by the primary care practitioner or the specialist. Risk number 1, they do have a loss of protective sensation, and they may or may not have a deformity. If they do have a deformity, we can consider prescriptive or accommodative footwear, consider surgery if the deformity can't be accommodated with the shoes, and to continue the patient education. These patients should be seen every 3 to 6 months by a specialist. Risk category 2 is peripheral artery disease with or without loss of protective sensation. These patients, we should also consider prescriptive or accommodative footwear and consider a vascular consult for the combined follow-up. They should be seen every 2 to 3 months by a specialist. Patients who fall in the risk group 3 have a history of an ulcer or an amputation, but they don't have an ulcer right now. So you want to do patient education, consider vascular consult, and make sure that they have the right shoes to accommodate their feet. And they should be seen every 1 to 2 months by a specialist. Now this is the Wagner classification scale, which grades the foot ulcer. And it talks about the grade that equals to the lesion. So a patient with a grade 0 has no open lesions. They may have deformity or cellulitis, but they don't have an open lesion. Grade 1 has a superficial ulcer. Grade 2 has a deep ulcer that extends to the tendon or the joint capsule. Grade 3 has a deep ulcer with an abscess, may have osteomyelitis or joint sepsis. 4 has local gangrene, which is in the forefoot or the heel or maybe the toes. And 5 is gangrene of the entire foot. So here are some pictures that help us to see our patients. Grade 0 is the pre-ulcer stage, but the skin is intact, may have redness and may have calluses and bony deformities. Amputation can be prevented at this stage, and the patient should be reassessed. They say annually. I would recommend every 3 to 4 months. If you can see on the right outer portion of the foot at the base of the little toe, there's a callus, and then the deformity where the great toe kind of turns in, maybe a bunion on the inner area of the foot. Grade 1 is the superficial shallow ulcer. They say to reassess every 3 months. I would say more often than that, depending on the patient's condition. Make sure that they have a offloading device and that the wound continues to get better. But they do have an opening in the skin. This we want to debride and offload, and there's different ways to do that. So you don't want a shoe that's closed and pressing against that foot. It looks like that's on the base, the medial aspect of the foot at the base of the big toe. The grade 2 is where we have the deep ulceration. They have tendon or bone visible, and these people need aggressive treatment right away. Here's our grade 3, where we have a deep abscess or abscesses. The patient probably has osteomyelitis, which is an infection of the bone, and they have a great chance of losing their whole leg if this is not tended to immediately. The grade 4 has localized gangrene of the toes or the forefoot. They need amputation of the gangrene part. This is not going to get better. This is a dead tissue that needs to be removed. Grade 5 is gangrene of the entire foot and sometimes the leg. And these patients really need aggressive treatment, including amputation of the foot and sometimes the leg. So this YouTube video is a demonstration of a foot screen, and it takes about 5 to 7 minutes, and I would suggest that you look at this either now or at the end of the video. I'm attaching the Louisiana State Board of Nursing declaratory statement on the role and scope of practice of the registered nurse in performing foot care interventions. And we can go over these now. If you have any questions or are interested in becoming a foot care nurse, the requirement in some programs are that you are a registered nurse, and there's you can become a certified foot care nurse through the WOC program. If you have any questions about that, I can help you get started. Thank you for your attention, and always remember to mentor our young nurses and to cherish our old nurses. If you have any questions, please feel free to call me. Thank you so much for your attention.